Hi guys, this is Jody. We're going to talk about week 4 in ATI Pharm Made Easy. This is your musculoskeletal system in which it gives you rheumatoid arthritis and osteoporosis. So what is RA? You're going to learn more about RA in semester 4, I can promise you. But this is a chronic inflammatory disorder that really has a range of symptoms. So it can be pretty mild to pretty severe. It mostly affects the joints, but in some it can affect the lungs. It can develop scar tissue in the lungs. It can harden the arteries and affect the heart. It can affect the blood vessels. So it can be pretty severe. It can also cause some significant like dry eye issues there too. But the main symptoms you see from the inflammation are tender, warm, swollen joints, joint stiffness, and then it has this systemic effect of fatigue, fever, and loss of appetite. So right there, it can be hard to diagnose at first because we don't know. These are fairly vague symptoms at first, but the real key ones here are those warm, tender, swollen joints. And again, it can be pretty life altering depending on how severe it is. So we want to have some treatments for that. So the treatments that the module goes in and talks about are 4 things: non-steroidal anti-inflammatory drugs. So this would be for a milder case. You could see aspirin or ibuprofen, something like that to treat the inflammation. If it's more significant, we could go towards steroids. So we could see corticosteroid therapy. And then the ones that they really kind of key in on, and that's why I have them bold, are the biologic DMARDs and the non-biologic agents. So the DMARDs are those disease-modifying anti-rheumatic drugs. If they're biologic, it means that they came from something living, whether it be an animal or a plant or something like that, whereas non-biologic did not come from that source. So the non-biologic we'll talk about is methotrexate. And this is a drug you will see again. We're going to talk about it in cancer because it is used to slow the growth of some cancer cells. But this is a potent anti-inflammatory drug that does have some significant adverse reactions because it can suppress the bone marrow. And we know that if we're suppressing the bone marrow is what produces our blood cells, right? So we can see this impact our red blood cells. So if we have a low red blood cell count, we see signs and symptoms of anemia, which can be fatigue, paleness. You can see increased heart rate, significant fatigue, that type of thing. If there's a decrease in the white blood cell count, it means the patient is at higher risk for infection, which they are anyway if they have RA. So we really want to be teaching these patients about hand washing, avoiding crowds, getting vaccinated, that type of thing. If we see a low platelet count, they're going to be higher risk for bleeding and bruising, and that is what this image shows. So we want to be watching for those signs and symptoms of an adverse reaction. Just because they're at risk for this adverse reaction doesn't mean they're going to have it, right? And so I posted a video with a healthcare professional that is educating about methotrexate in particular, and some of these drugs or other drugs that you might see for RA, because we talk about these adverse reactions and it can really scare patients to say, really, what's worse, the disease itself or the treatment? It's like, okay, so I might have less inflammation, less pain, but I might have these problems. So it's really important to consider the approach when you're teaching patients because remember, we're holistic, we're looking at the whole picture, and we do need to address those fears. So I thought it was a really good video and how she kind of goes forth and addresses some of the concerns related to side effects and adverse effects of drugs for RA. So, as far as looking at levels of, I know you guys are kind of just learning about labs and levels. If you're tested on a level of something you need to be watching for, just really key into if it's important for me to give you the normal levels, I will, but it's really more important to know not memorizing levels, but what you should be looking at. Like, what would I be concerned about? What should I be looking at in the labs? That type of thing. And for this in particular, you would really be keying in on and looking at their CBC, that complete blood count. So we talk about biologic DMARDs, and the one that we'll talk about is the etanercept. So this is an injection. It's sub-Q that they get once a week. Sub-Q, so you see it's going in at that 45-degree angle to get to the subcutaneous tissue. And this also increases the susceptibility to infection. So again, we're just teaching, hand washing, no live vaccines, but we do want them to get vaccinated to prevent flu, COVID. If they are older and qualified, which they would if they have RA, most likely can get the pneumonia vaccine as well. So we want to make sure that they're getting vaccinated. The other thing that kind of stands out with this drug is that if a patient has latent TB, which means they've been exposed to it, it's kind of sitting in their body, but it's not active, so they don't have active TB. But if it is in their system and they have that latent TB, we can put them at risk for more lung damage and for that latent TB to become active. So we want to test them for tuberculosis before starting therapy with this drug. That really is the main stuff with RA. And again, you will talk more about RA when you get to fourth semester. Then we're going to talk about osteoarthritis. We hear a lot about this, especially with older individuals and with women, especially as they get into that age where they're in menopause. And this is when the bones can become weak and brittle. And so the big thing with diet, we want to push diet, is with calcium and vitamin D. So we want the calcium in there to strengthen the bones, but they need the vitamin D to actually get the calcium into the bones, okay? Symptoms of osteoarthritis, this is going to be back pain because they can have broken or collapsed vertebrae, loss of height, stoop posture. You might see individuals who are, falling and breaking their bones very easily, and they can be weak and more at risk for falls. Medications, we can see selective estrogen receptor modulators. So raloxifene is the one that we're going to talk about there. We can see biophosphonates, and this is alendronate that you might see, calcitonin, and calcium supplements. So these are the ones that we're going to talk about. You're going to talk more about osteoporosis later in, I think, fourth semester too. I think it's fourth semester as well. So raloxifene is one that is usually used for postmenopausal osteoporosis. It may also be a drug that's used in the treatment of breast cancer. Let's see. Because the adverse drug reactions have to do with blood clots, we see stroke, DVT, and PE. PE is pulmonary embolism. These all have to do with blood clotting. So this would be something that we would not want to use if a patient has a history of blood clots, because this is a significant adverse, life-threatening adverse reaction. It doesn't mean that a patient is going to have it. It doesn't mean they're going to have this adverse reaction, but they are at risk for that with this drug. So we would want to, really, it would be contraindicated for a patient who has a history of blood clots. It may also cause some hot flashes. Okay, biophosphonates, so alendronate is the one drug. The big thing with this in nursing considerations is how we administer it, because patients can have pretty significant esophagitis, so irritation in their esophagus when they swallow it. And I got to tell you, I was teaching this in class. We were kind of going through it, and this student said that she's an LPN that worked in a nursing home, and she gives this drug all the time, and she never knew that she was supposed to be giving it to a patient sitting up, and that they really should be sitting up or standing for at least 30 minutes. So in order to prevent the irritation in the esophagus, we want to make sure that the drug goes all the way down, that we rinse it, that there's no residue of that medication sitting in the esophagus. And the reason that we sit them up or keep them up for 30 minutes after is we know that after people swallow things, and they take things in, they can kind of regurgitate or bring stuff back up into the esophagus. So we want to make sure that we're preventing that. And so we keep them sitting up or standing for about 30 minutes after taking this drug. So if they're taking alendronate, they should be taking it with a full glass of water, sitting upright for 30 minutes, or standing for 30 minutes. So they're in their upright position. And again, that just prevents that esophagitis. The calcitonin in salmon, just remember salmon is fish. They cannot take this if they have an allergy to fish protein, because it does put them at risk for an anaphylactic reaction. So if a person does not eat fish, they don't know if they've ever had a reaction to fish, This would be something if we give it for the first time in the hospital, we want to have some epi available because they can have a pretty significant anaphylactic reaction if they do have a fish allergy. We also want to make sure with all of these patients, we're providing a diet high in calcium and vitamin D. Okay. And this drug in particular can be given intranasally. And then calcium supplements. So I have Tums here. I'm sure most of you have taken Tums before. They're chewable, they taste good, easy to get down with any antacids, and we'll talk about this more when we talk about the GI system. Should be taken with a full glass of water. Okay. So again, this is calcium supplementation. So we would not want to give this to a patient who has hypercalcemia, so high calcium levels. Okay, sometimes you'll see that in patients with cancer that has spread to their bone. You might see hypercalcemia. Also, this puts them at high risk for kidney stones. So if they have a significant history of kidney stones, we would want to be very cautious with this. But otherwise, it's an over-the-counter calcium supplementation. There are all sorts of calcium supplements out that you can purchase over the counter. So those are usually the big ones in prevention and treatment of osteoporosis. And that's it. So this week is pretty light. There's not too much. So I would definitely jump back into week 3 and look at those drugs. So you want to be reviewing week 3, week 4, and then next week you'll have week 5. And that gets pretty heavy because your second exam is going to test on weeks 3, 4, and 5. So just make sure that you're continuing to go over these drugs and reach out if you have any questions.